Hello.
Hello, Dr. Majid. Good morning. Sushant here.
Good morning.
How are you, boss?
Yes, I'm getting.
Yeah, good morning, Dr. Mathew. Good morning.
Good morning. I'm just waiting for things to start.
yeah. Dr. Majid, all set. So you are the host now, Majid?
Yes, ma'am.
Okay. So just, I think, 2 minutes to go and we'll start.
Okay,
Good
ma'am.
morning. Good morning, everyone.
Hi, ma'am. Good morning.
Yes. Nice to meet on the Sunday mornings.
Good morning.
It's 10 o'clock.
So good morning, everyone. Thanks for joining and welcome to the third Trauma and Acute Care Grand Round. So I welcome you all and extend my warm greetings from Indian Society for Trauma and Acute Care. So this is our third webinar on the last Sunday of the month, as we had all decided. And I'm happy to see that a lot of people have joined by now. And today we have a very renowned panel of experts. We are joined by Professor Joseph Matthews, a good old friend from CMC Vellore. Professor Matthews is a senior professor and of neurosurgical sciences from Christian Medical College, Vellore. He is joined by Dr. Swati Jain, who's a neurosurgeon from the Division of Neurosurgery, NUHS, Singapore, and also joined by Dr. Ming, who's consultant of hepatobiliary and trauma surgery from NG Teng Pong Hospital, NUHS, Singapore. So, and the case will be presented by AIIMS Patna today under the leadership of Dr. Majid Anwar. Dr. Majid Anwar is assistant professor at AIIMS Patna. So, I'm handing over the session today to Dr. Mathew Joseph to continue forward. Thank you.
Okay, I wasn't quite aware I was supposed to run the session, but thank you. Welcome, everyone. Since Dr. Sushma has already introduced my co-experts, I think we won't waste any time. We'll go directly to the presentation.
Has
So,
Dr.
Abhishek, please
Swati
go
and
ahead.
Dr. Ming joined?
Dr. Ming is.
Morning, I'm here. Yeah.
Yes. Okay.
I'm
Fine.
not sure about Dr. Swati. I didn't see her name. Anyway, shall we begin? Not waste any time. Dr. Abhishek?
Dr. Abhishek to start.
Good morning, sir. Myself, Dr. Abhishek Kumar, a senior resident from Department of Trauma Surgery and Critical Care, AIIMS Patna. I will be presenting an interesting case over double trouble.
Will everybody else please mute your mics? Will all the attendees please mute your mics? Thank you.
I will be dividing the case presentation in 4 learning points. There will be case scenario, diagnosis and management, and discussion and take-home messages. Uh, a a 14-year-old boy came to our emergency department with history of road traffic injury. Cyclist hit by a speeding two-wheeler. It was a side impact and presented 2 hours of after injury. Directly brought to trauma center of AIIMS Patna, and no treatment was received outside. Mechanism of injury was it's road traffic injury. Suspected injury was head injury. Sign and symptoms: patient was having loss of consciousness and vomiting multiple episode. There was no ear, nose or throat bleeding or seizure. Treatment was not given outside. Primary survey airway was threatened in view of low GCS. Patient was intubated with 7 mm of cupped ET tube and cervical spine was stabilized using hard cervical collar. Breathing, patient was connected to mechanical ventilator and was kept on ACVC mode. And the tidal volume was set at 330 ml and PIB was at 5 centimeter of H2O, and FiO2 was generating 100% and respiratory rate at 18 per minute. Air entry was bilaterally equal and SpO2 was 100% and chest compression test was negative. Pulse was at 88 beats per minute. BP was 96 by 54 mm of Hg. Pelvic compression test was negative. FAST was negative in subxiphoid, perihepatic, periasplenic, and in pelvis. Patient was having GCS of even VT M4. Pupil was bilaterally 4 mm and reactive to light and moving all 4 limbs equally. Patient hypothermia was prevented. Adjuncts chest X-ray, pelvic X-ray, and EFAST was within normal limit. Second, ample history was patient was not having any history of allergy. No previous medication was being taken. No past illness. Last meal was taken 6 hours back, and event was road traffic injury, and he was cyclist being hit by a 4-wheeler from the side. It was a side impact. Head and maxillofacial, there was raccoon external wound and a laceration of size 2 into 2 into 0.2 centimeter in left temporal region was noted, which was a clean cut and superficial wound. Neck and neck was normal. Chest air entry was bilaterally equally and no added sound was present. Abdomen and pelvis, no tenderness or organomegaly were noted. Logral, no step deformity. Distal rectal examination was normal and peripheral pulse were palpable. Then we moved forward to investigation. NCCT head was done. It was showing 3D recon picture was showing bifrontal and biparietal undisplaced fracture. And CT head was showing left frontal EDH with right frontotemporoparietal SDH with multiple contusion. Diagnosis was made of RTI with severe head injury with left frontal large extradural hematoma with mass effect and right side frontotemporal parietal contusion. Plan was left frontal craniotomy and evacuation of EDH hematoma, EDH. Blood for cross match and baseline lab parameters were sent. Patient was then directly shifted to OT. Procedure, we went with the curvilinear incision made behind the hairline in left frontal region, extending to the right. Subcutaneous tissue dissected and margins secured using Greenwich clip. A frontal undisplaced fracture noted extending from left to right. A burr hole was made and bone flap raised using craniotome. EDH of 150 ml evacuated and hemostasis was secured using Bobby cautery. Dural is taken and bone fixed with screws and plates, wound closed in layer. Here we can see intra pictures. First picture is showing fracture of frontal bone and parietal bone. Second picture we can see after craniotomy there is left frontal EDH. EDH evacuated and hemostasis achieved. And third picture is showing bone fixed with titanium plates and screws. Post-op event, patient was shifted to ICU. Patient was intubated. Immediate post-operative GCS was E2 VT M5. Pupil was bilaterally 3 mm reactive to light. Post-op NCCT done after 6 hours, suggestive of right contusion with mild mass effect present. Here you can see post-op CT scan. Here you can find left frontal EDH evacuated. Here you can see that no, there is and in right frontotemporal parietal SDH and contusion can be seen. Patient was then started in ICU with cerebral decongestant 20% weight by volume injection mannitol, 100 ml IV stat was given and followed by 100 ml every 6 hourly. And anti-epileptic injection phenytoin sodium loading dose was given at the time of presentation in ED and it was continued at 100 mg IV every 8 hourly. Antibiotic injection ceftriaxone 1 gram IVBD and injection metron IV 500 mg IV TDS and injection amikacin 1 gram IV OD was given. On POD2, there was no improvement in GCS and NCCT head finding was suggest on the basis of NCCT head finding. So tracheostomy was done. Drop in GCS noted on POD3. It was E2 BTM4. Pupil right pupil was 5 mm sluggishly reactive to light and left was 2 mm sluggishly reactive to light. Vitals patient was vitally stable. Patient was then immediately shifted for NCCT head in view of fall in GCS and anisocoria. Patient was then shifted directly to OT as there was increase in the size of SDH and mass effect. Here you can see the CT. Previous CT was showing right frontoparietal SDH and contusion, which was less in size. But after fall in GCS, then CT was done. Right frontotemporal parietal contusion with surrounding edema with effacement of cistern can be seen. Then patient was prepared for the second OT. Right frontotemporoparietal decompressive craniectomy was planned. We took the reverse question mark incision, skin and subcutaneous tissue dissected, and full thickness flap, skull flap elevated. Subperiosteally while preserving superficial temporal artery. 4 burr holes made along the frontoparietal and temporal region, bone flap using craniotome. Dura cut open using cruciate incision. Hemostasis was achieved. Lax duroplasty done. Subglial drain placed and wound closed in the layers. Intra there tense dura and right FTP contusion and SDH noted. Brain was pulsatile. We can see angry brain and no active bleed was noted. Post-operative patient was shifted to ICU. Cerebral decongestant and anti-epileptic continued. Post-op GCS E2 VT M5. Pupil bilaterally 3 mm reactive to light. On POD5, GCS improved to E4 VT M6. And pupil was bilaterally reactive to the light and it was 3 mm. Gradually, patient was weaned off from ventilatory support and shifted to normal ward. The patient was discharged at POD18 after successful decannulation. A story after 4 months. In follow-up period, patient was having GCS of E4, V5, M6 and pupil was bilaterally 3 mm and reactive to light. Patient was then readmitted in a ward for elective titanium mesh cranioplasty. Then we proceeded with another surgery of the patient and mesh cranioplasty was done. Incision was made along the previous craniotomy scar. A scalp elevated while preserving vascular supply and bone is smoothened and pre-contoured mesh place was placed over the skull defect. Here you can see the post intra-op image of the patient underwent mesh cranioplasty. In this case, we can see there was timely surgical intervention in case of severe traumatic brain injury was needed. Emergency left frontal craniotomy with EDH evacuation was performed on the day of trauma. And a second surgery, right decompressive craniectomy was needed due to GCS drop, highlighting the need for vigilant monitoring and prompt neurosurgical action. GCS as a dynamic clinical tool, initial GCS was even VTM4, prompted early intubation and ICU care. A decline on POD3 led to repeat imaging and surgery. Subsequent GCS improvement E4 VT M6, guided ventilator weaning, tracheostomy removal, and cranioplasty, underscoring GCS role in ongoing management. Multidisciplinary stepwise care enables recovery, a structured management, trauma stabilization, dual neurosurgery, ICU care with decongestant and ventilation, followed by rehab and cranioplasty, resulted in favorable recovery over 4 months, stressing the importance of integrated neurocritical care. Discussion, intracerebral hemorrhage occurs in 13 to 48% of adults with traumatic brain injury, with 13 to 17% of these showing Contrecoup hemorrhage. Contrecoup injury typically occurs when the moving head of brain strikes a stationary object, whereas coup injury is associated with moving object impacting a stationary head. Contrecoup lesion occurs due to force within the intracranial cavity that are not directly linked to the side of focal blow. Cause false road traffic accident, age mostly in young males, location temporal area. Theories of Contrecoup injury. Positive pressure theory it specifies these stresses are caused by the brain lagging the initial movement of the skull, followed by brain compression against the opposite stationary irregular skull. The moving brain hits the opposite side of the skull, typically at the bony prominences, and creating a contusion. Negative pressure or cavitation theory, movement of the brain in one direction generates stress to the opposite area of the brain and cause damage to the cerebral tissue at the point. Rotational stress theory, the rotational stress theory incorporates a rotation of the brain and displaced along the axis of the trauma. Angular acceleration theory postulates that the brain is tethered in some areas, such as brain stem, causing specific areas potential for greater acceleration and deceleration of the brain. Evaluation of the patient. Mechanism of injury was evaluation mechanism of injury: fall from height or road traffic injury. A high index of suspicion based on the mechanism. History: a detailed history should be taken, including loss of consciousness, oriented or confused, vomiting, speech alteration, hemiparesis, or seizure. Evaluation proceeds along the advanced trauma life support protocols. Look for GCS, pupils, reflexes, and lateralizing signs. NCCT head after secondary survey. Management, a small contusion or mild and moderate traumatic brain injury, close clinical monitoring with repeat head CT at 12 or 24 hours is indicated. Neurological status with GCS less than or equal to 8, ICP monitoring according to Brain Trauma Foundation guidelines. Some patients require surgery depending on the neurological examination and the type and size of the injury. Intervention can be done as drainage of hematoma in extradural or subdural space. Decompressive craniotomy is the last resort of the surgical management. Anti-epileptic medications for 7 days according to Brain Trauma Foundation guidelines. Countercoup part of other injury and address other bodily trauma in the polytrauma patient as per the guidelines, ATLS guidelines. Key learning points: unmasking contralateral lesion, evacuation of large hematoma. EDH reduces intracranial pressure, potentially revealing or worsening a previously compressed contralateral hematoma, subdural hematoma, contusion, or edema due to loss of the tamponade effect. Need for postoperative imaging. Routinely early postoperative CT is essential to detect new or expanding contralateral mass effect, particularly in the patient with neurological deterioration or lack of expected improvement, guiding urgent intervention. Pathological mechanism: decompression can cause brain structure shift, leading to vascular engorgement or tearing hemorrhage, distribution of intracranial contents, CSF or blood, or loss of autoregulation, promoting reperfusion injury and edema. Thank you, sir.
Thank you, Dr. Abhishek.
Thank you. Thank you,
Okay, I'd like to make a few comments before we throw this open for general discussion and questions.
Okay.
Two are your neurosurgical details. Okay, one is when you've done your first scan, you know there's a left frontal extradural,
Yes.
but you also know that there is a very potential second surgical lesion on the right side.
Yes.
So doing a pure bifrontal flap, which I think is what you've done, may be causing difficulties for you later, because if you need to extend it backwards, then you make a separate incision which joins with your previous flap, and then you have an angular you have angles which may prove difficult with vascularity.
Yes, sir.
The second thing is when you have a patient with a fracture across the sinus, taking craniotomies near that area can sometimes cause severe sinus bleeding from the sinus itself. You have to be aware of that. Okay, so those are two neurosurgical nuances that I thought I'd mention. By the way, I forgot to ask, is Dr. Swati on board?
Yep, I'm here. I'm here. Yes.
Okay, so Swati, you want to take over first? Have you heard the full
Sure.
presentation?
I mean, you can go ahead and finish your thing, and I can chip in a bit. Yeah.
Okay, then to continue, we don't generally give that much antibiotic for our post-op patients. If it's a non-compound wound, there's no laceration involved. We just give single dose antibiotic perioperatively, but that is protocol depends on each situation. Early track, I can see a lot of people arguing that the track was done too early, but we also tend to do our tracks early, mainly not because I convince the patient will need a track, but a tracheostomy speeds up your weaning and removal from the ICU. And in most of our places, ICU beds are like gold. So if you can get the patient out of ICU fast, tracheostomy for us is not a very morbid procedure. And we can actually get the patient out of the ICU and we can, in CMC,
There is a lot of background noise. Can you please mute the other people,
just
please?
mute your mics, please. Vikas Garg is making a noise. Can Vikas Garg please stop making a noise? Vikas Garg is making a noise. Can you please mute your mic? Can the controller mute it?
Majid, you are the host. Maybe you can mute them.
Can you mute Vikas Garg? Who's making? Okay. Anyway, right. So what we found when we looked at our patients, we don't keep our patients for very long. We keep our patients 1 week or 10 days. And we found that in that period, we were decannulating 1/3 of our patients with tracheostomies. All right. In other words, possibly those tracheostomies, if you look at it theoretically, those tracheostomies could probably have been avoided. But if we had avoided those tracheostomies, we would have blocked our ICU beds for many more days. And that's a trade-off each center has to make on its own. Okay. One thing I was intrigued by is your ability to provide GCS scores throughout the course of the patient's stay. Dr. Abhishek, are you giving the patients sedation holidays, or are you just sedating them very lightly?
No, sir, we give sedation holidays, sir. Just before checking the GCS, we always stop the.
Sorry, I can't hear you. Just a little louder.
Sir, we give sedation holidays to the patient, sir.
How frequently? Every day? Twice a day?
Sir, before taking rounds, sir, we always stop sedation half an hour ago, sir, to just get the accurate GCS of the patient.
And what is your sedation?
Sir, we keep the patient on injection midazolam, sir, and atracurium, sir, and many a times we give propofol, injection propofol, sir.
Okay. Right. So I was a little intrigued by that because there is actually a paper from the civic group on when you can do sedation holidays. It's a traffic light map thing, red, green, yellow. I think that might be worth looking at. I try, while questions are going on, I try and find the reference and let everybody know, when sedation holidays are safe and when you can do them. It's not always safe. Then one more thing I'd like to say is one of your things you suggested is routine post-op early CT is necessary. Okay, I would tend to disagree with that. It would depend on what you expect. If I have a pure extradural, I've taken it out. I don't want to do an extra, and I'm sure of my hemostasis. I don't think I would do a routine post-op CT. If I had doubts about some potentially progressive lesion, yes, I would do a post-op CT. Otherwise, I would not. And the last thing I want to say, which is a miscellaneous thing, don't use the word decongestant. That is not a universal. That may be a local terminology. It's not a universal thing. The universal thing we say is osmotherapy. Okay, decongestant is not something. Decongestant to me is something you put in the nose, not in the brain.
Yes.
All right. So decongestant is not an appropriate terminology. Might be better to say osmotherapy. Okay, Dr. Swati, anything to add?
Thanks, Dr. Joseph. Abhishek, great case presentation. And I thought I'll just mention a couple of points. And I think, Dr. Joseph, yourself, you've mentioned a few of them, but I think your case is a very, very good reflection of how different TBI management can be, and yet patients can have an excellent outcome, which was the case in your case. I think if you can just move the slides. I thought I'll just mention a couple of points which you have mentioned so far, and I'm happy to take questions. So your case is a very good reflection of how you can achieve an excellent outcome without having the nuances and the pearls of a neurotrauma management that is often stated, when there are guidelines that come out of, whether it's the American guidelines on management of TBI, or it's the British Trauma Foundation, or whatever is used as the standard of care. But a lot of questions are now being asked whether that standard of care is truly necessary or we are monitoring too much. So I just wanted to mention a couple of points which I took down. If you can go back to the very first scan, which you showed, the cuts, which you showed where there's an EDH and a contralateral large contusion. And I can go through a bit. Yeah, that's the scan. So for everyone out there, I think, and I think this is something Dr. Joseph mentioned, when you see an EDH that's going up to the midline, that's fine. If you see an EDH that's going up to the midline, I'll be very, very careful when I'm doing a craniotomy, because in this case, if there's the laceration is actually all the way up to the sagittal sinus, you can lose control extremely easily. And your aim in the surgery has to be just an evacuation of the EDH, enough to remove the mass effect. So you should not be looking at, having a beautiful post-op scan, because if you chase that, and if you chase that intra-op, you're going to lose absolute control, because sometimes it's just the small amount of bone that's sitting up on the sinus that's actually preventing the EDH, that's actually preventing the sinus from exsanguinating in front of you. So in the, I couldn't really tell from the intraoperative flap how your flap was. But in this case, to be very honest with you, just like Dr. Joseph said, I would do a standard trauma flap just on one side. I won't really do a bicoronal flap, purely because it's going to be a little difficult to, to control. Or the other option in this case really would be to do a full bicoronal flap, because you could do a craniotomy on one side and potentially do a decompressive, kind of just a frontotemporal craniectomy on the other side if needed. Because what you're worried is you do not want to make an incision that makes it difficult for you to do the surgery on the other side, because that's what my main concern is going to be, that the contusion on the contralateral side is going to blow up at some point of time, which is what happened in your case, right? And your craniotomy is a very good reflection, because you've done a relatively small craniotomy. You've stayed away from the midline. You can see the fracture line that's going towards the midline, and that's important. And the other thing also you want to make sure, which I'm not sure you did it in this case, is when you're doing something so frontal, you have to be aware where the frontal sinus is. So in your case, depending upon what your available adjuncts are, I would prepare a pericranial flap in this case, just in case I enter the frontal sinus and I want to do a cranialization of sinus in the same setting. So when you're doing such frontal craniotomies, you want to be just be a bit mindful and prepare a pericranial flap if you don't have any other adjuncts, like DuraGuard and things like that, which you can use. But I usually tend to have a vascular pedicle flap purely to make sure I do not enter the sinus. I think the second question, I think the second point that Dr. Joseph mentioned was your sedation hold, or we call it sedation hold, or you can call it sedation holidays, whatever you do. In your case, it's very interesting. You have a GCS right post-op of a E2M5, which I presume that the sedation was completely weaned off, and you did not have any kind of intracranial pressure monitoring. But that being said, you know, again, like I said, there are more and more literature that's coming out in terms of, you know, whether intracranial pressure monitoring is absolutely necessary, or whether we end up with poorer outcomes because we tend to keep these patients sedated for a much longer time. So if this patient was being managed with the way, you know, with the guidelines of, say, for example, BTF. So this patient would have a ICP monitor on the contralateral side, which would be on the right side because there's a large contusion. The patient will be kept fully sedated, you know, irrespective what the post-op scan looks like, purely because this patient's contusion, given the young age, is likely going to blow up, which is what happened in your case, albeit just a few days down the line, right? So it kind of naturally declared, but this is something I'm always a bit careful of, because if they do have a large contusion, even though your post-op scan looks fantastic, I'll keep them sedated purely because you just want to give them a bit of rest before you start weaning sedation off, because that becomes a big problem. I think in terms of, I completely agree with Dr. Joseph in terms of early trachea, because trachea, to me, is not a morbid procedure at all as compared to whatever the patient has gone through. You know, early trachea means you wean them off early from the ventilation. You can get them to rehab relatively quickly. And, that's really a very small part of, you know, the big picture, which you have been managing. I also agree, I don't give them such strong antibiotics, unless and until there's an open laceration. They just get, you know, pretty much either a single dose if they're in a center in UK. If they're in Singapore, they get 24 hours of antibiotics. That's about it. And the last thing, I'm happy to take any questions because I don't want to take too much of the time of discussion from the audience. I think the other thing which I feel that you should mention, or when you should look at when you're doing these presentations, is actually your blood pressure or your systolic blood pressure or your MAP, because in the absence of a ICP wire, you don't really want to make sure they are fully perfused, you know, like in the presence of an ICP wire, you say, oh, your cerebral perfusion pressure should be more than 60. And you just want to make sure, especially in a young patient, they're well perfused. So usually you end up keeping them a bit hypertensive rather than a bit normotensive. So some people say use a MAP target of more than 90, use a systolic of 120. This is in the absence of any ICP monitoring, which you should you know, kind of look at. I mean, it's great. Patient had a great outcome. Patient is GCS 15. And I can see you used a moldable titanium mesh to do a cranioplasty. I think all in all, this case is a very good reflection of how you do not need multimodality monitoring, because either ways TBI would declare itself. But it's always difficult to tell at what point, a monitoring would have made a difference of early intervention, or at one point, just a plain interval CT scan could have made a difference. I agree with Dr. Joseph. We don't use decongestants. It's called hyperosmolar therapy. You have used mannitol. You can use 3% hypertonic saline. Both are easily acceptable. Again, what you have done is done an empirical treatment, which has worked, because a lot of times what happens is we start chasing numbers. And sometimes I have started going back from chasing numbers. So I'll tell my resident, stop telling me what the ICP wire is. The scan looks fine. I'm going to off the sedation and I'm going to wake the patient up, because sometimes you end up keeping the patient sedated very long because you just have so many numbers to deal with. But those are my couple of points, but I'm happy to take any questions if there are any from the floor. Yeah.
I think after Dr. Ming gave his input, I think after that we can take the questions from the one by one. So Ming,
thanks for the invite to share my thoughts. As you all know, I'm a trauma surgeon, but general surgery is my specialty. So I'm a little bit of fish out of water right now. Of course, a lot of the points of
just a minute, somebody, well. Supreet Kaur,
please mute your mic. I don't have the controls here.
Okay,
please.
Thank you.
Thank you.
Yes, continue.
Yeah, a lot of things have also already been shared by my previous two colleagues, Dr. Mathew as well as Dr. Swati, about antibiotics. I suppose at the end of the day, if I assess this case, I really have just two questions to throw back to Dr. Abhishek. Number one is, now that you know what has happened, and congrats on a good outcome after a challenging case, would you have made any difference in managing this case? Whether I'm not sure whether there's a role of ICP, for example, in after the first op. And secondly, of course, it's also that I'm not sure I read the slides correctly. But you were saying that there was a GCS drop on day 2. Was there a scan repeated then, or not? And whether there was any role for an early intervention, right-sided decompression after the day 2 instead of waiting for day 3.
Yeah.
Lastly, I guess a very interesting question for me to you would have been, if this guy had a concomitant abdominal injury, would we have done anything very differently? For example, he had a very bad spine laceration, was hypotensive for a short while and went in and did splenectomy. Would there be any change in management for you instead of doing something so drastic, something more temporizing and of a lesser severity? Yeah, thanks.
Yeah. So thanks for the panelist input, rightly pointed by Dr. Mathew Joseph and Dr. Swati Jain and Ming. I just want to clarify a few things that we do at our center. First is regarding the sedation. So what is our practice at our center is we start with fentanyl infusion and we just do the on and off stoppage to look for the GCS. Regarding the ICP monitoring, currently we don't have any invasive way of monitoring the ICP. So what we do is we use a couple of things, radiological parameters, clinical parameters, and we have got using a non-invasive way, using the optic nerve sheath diameter. We have got recent publication at our center where we use the criteria of more than 5 mm as a indicator of raised intracranial pressure. So yes, every time whenever a patient comes to the ED, we get a ICP, and whenever there is drop in GCS, along with the CT clinical parameter, we also do a routine ICP using the optic nerve sheath diameter, and then we proceed along with surgery. Regarding the third point, rightly pointed out, we use a lot of antibiotic, particularly in the Indian context and particularly in this part. We try to cover the gram-positive and gram-negative organism. These organisms are the most commonly present at our center, and according to the hospital antibiotic strategy, we cover the gram-positive and the gram-negative. Regarding the cerebral perfusion pressure raised by Dr. Swati Jain, so yes, she has rightly pointed out the cerebral perfusion pressure, they play a very important role in keeping the brain alive, and we keep it more than say 90, or MAP should be somewhere on 80 to 90, and we avoid giving any hyperosmotic therapy whenever the BP is low. We have a practice of giving 3% normal saline as a bolus or as a continuous infusion. But those patients where the BP is low because of some other injuries like abdominal injury, thoracic injury, so in those patients, we avoid giving any hyperosmolar therapy, mannitol and the Lasix. Regarding Dr. Ming, he raised like what we do in polytrauma patient. So in polytrauma, they all managed by the advanced trauma life support protocols. Any patient who has got abdominal injury in the form of splenic injury, we manage according to the ATLS guideline. We do a routine fast examination. We do, if a patient has got fast positive, we go for a CT scan of the abdomen. And based on the hemodynamic status, either we go for a non-operative or operative management. Either we do splenectomy in the operative period, or if patient is kept on non-operative management, then we simply observe with hemodynamic like BP, pulse, abdominal girth, hematocrit, serial hematocrit measurement. That is what we do at our center. So I think that is what I just clarified few things, and I'd be happy to answer more of the things from the, I think we can take the question now.
Dr. Majid, can you read the questions in the chat box?
Yes, ma'am. I'm just reading one by one.
One by one, yes.
Yes, I think regarding GCS, it was even VT M4 initially, and right after the patient deteriorated, it became to M3, and then when decompression was done, he recovered to M6 status. That's what I can say about the GCS. Yes. What is the role of optic nerve sheath diameter in such cases, and how should we include optic nerve sheath in primary survey of ATLS? Dr. Swati, would you like to answer?
Yes. So, Dr. Majid, I think it's great you've mentioned optic nerve sheath diameter. I didn't want to say it because I wasn't sure if it's something that you guys do. So, the thing is, optic nerve sheath diameter, just to give a bit of background. So it's basically a non-invasive way of doing an ultrasound where you put an ultrasound basically on your eye and you truly measure the diameter of the optic sheath. And there are different parameters, but usually more than 5 or more than 6 millimeters is correlated with ICP of more than 20, or just the fact that you're dealing with high ICP, basically. And the good thing about optic nerve sheath diameter is because it's completely non-invasive. It's meant to reflect a global kind of ICP situation in the brain. So it's very good for settings where you do not have an invasive monitor. The drawbacks of obviously optic sheath diameter is that there's a lot of inter-user variability, because, for example, if somebody said, oh, I saw 4 or I saw 5, are you going to take the 4? Are you going to take the 5? And you do need to do it relatively frequently, because it's not like a continuous number that you're going to get. I mean, obviously, I think there are more, not studies, but I think people are trying to develop some automated system where, you know, there's an automated recognition and you get numbers relatively quickly to take away the inter-user variability. So in terms of when do you do, so for example, in this case, it doesn't matter what the optic sheath diameter is going to be when the patient came into the ED, because you look at the scan, you're dealing with someone who has intracranial hypertension, there's mass effect, you're going to go in irrespective, right? So in this case, it makes absolutely no difference to do an ICP, to do optic sheath diameter right up front. What it will become very important will be in the post-op settings, right? So for example, there are 2 ways of looking at it. And I think Dr. Majid mentioned it very clearly, that you have different parameters of assessing when the patient is, you're dealing with someone with high ICP. So your radiological parameters, in this case, a CT scan. If the CT scan shows there's a big contusion that has become bigger, the midline shift is now on the right towards the left side, that is your radiological evidence. I don't need an optic sheath diameter to tell me that the ICP is high. Clinical, if the patient's one-sided pupil is dilated, which helped happen in this case, again, I don't need an optic sheath diameter to tell me that the ICP is high. So those are the 2 parameters that would take higher. However, if the pupils have been reactive bilaterally, regularly post-op, I do not have the capability of sending the patient for a scan on a regular basis, or the patient is really unstable, you know, to be sent for a scan. Like, I mean, in a different setting, you know, people will have scan 3 times a day. People will have scan 10 times a day every time there's a change in number of the ICP. In those scenarios, you can do a regular optic nerve sheath diameter monitoring, because in that side, it gives you kind of an indication, because everything else is stable, you're using a third adjunct to actually monitor the ICP. How long? I think just to give you, I think there's somebody who had asked this question in terms of what is routine post-op CT scan, do you do it? So the reason I routinely will do a post-op scan, not right after OT. I give them 24 hours and I do a CT scan the next day, purely because if I'm happy intra-op, you know, why should I scan the patient? Pupils are all right. You know, it is a big call for the anesthetist, for the ICU doctors to push the patient to a scanner. And, you know, it is quite cumbersome and troublesome to send the patient for a scan right from OT. So I do not usually scan right immediately up front. I do a scan at least in 24 hours, unless, you know, there's a change in anything else. If this patient was just a pure EDH, I think Dr. Joseph mentioned this as well, with absolutely no other injuries, the GCS was depressed purely because of the EDH. In fact, I would wake the patient up right up front. I would not give the patient any sedation. I would wake the patient up right up front, because I do not expect any further injuries. I do not expect the contusion to blow up. And in that scenario also, I don't really need a CT, because my post-op, intra-op, I already know what kind of a job have I done. So those are some of the factors you have to take in. The reason why a protocol doesn't exist, so if you read some of the guidelines, there's no protocol about doing an immediate post-op scan or doing ICP monitoring, because the issue is that every center is going to have very different resources. And this case, I cannot emphasize enough, is such a good reflection that despite an absence of ICP monitoring, patient can have an excellent outcome purely because you have been doing everything else very, very sequentially. And just for everybody out there, you can actually pull up a paper. It was just recently published, I think last year. It was a meta-analysis which was published in WFNS, World Neurosurgery, sorry. And it was interesting because that paper actually said they think that the ICP monitoring can be detrimental to patients' outcome, because in those cases, like I said, you follow a number, you don't wake the patient up, they get loads of sedation, and sometimes they even reach things like barb coma, and when they actually do not need. So there's a lot of nuance, and I don't think we would have time to do that, and I do not want to take more time because there are probably more questions. But that is something to take note of, that people were moving very much into, brain tissue oxygenation, into microdialysis, into ICP, and all these things were coming in. But most of the TBI does occur in places where people don't have access to this, people don't have access to more than a scan. And are you going to subject these patients to all this purely because some company has come up with this? So there's a lot of ethical and struggle as well in those scenarios. And I think just one thing I would mention just quickly in terms of invasive monitoring. So in the absence of everything else, say you don't even have optic nerve sheath diameter, but you do have an ultrasound, one way of doing an ICP monitoring is actually to put in an EVD or an external ventricular drain. You don't need to have a proper EVD. You can actually put in an NG tube. The neonatal NG tube works completely fine, or a neonatal catheter can go into the ventricle, and that's more than enough, which you can connect to your standard arterial blood pressure monitor, and you can get an ICP reading. But again, I really can't emphasize enough how good this case is a reflection that you do not need ICP monitoring most of the time. So yeah.
Yes. So you have, I think, clarified most of the things. The third query is how many patients require surgery for Contrecoup injury? I'll clear it. Most of these patients, sir, they undergo non-operative management using GCS charting and cerebral decongestant, and they can be discharged after, say, a week of stay. Few of the patient, 1 or 2%, they require an operative intervention. And regarding the second query, why did not you use patient bone for cranoplasty? Like in this patient, we use the titanium mesh. So actually, during the surgery, there was a frontal bone fracture. So if we try to do do the cranoplasty using autologous bone, it's very difficult. We have to solve the puzzle, and then we have to fix the bones. So that was the difficulty. So we, because of the fracture, we discarded the bone, and in the next setting, we used the titanium mesh. The third query, how early we can consider anticoagulation in such patient, and is there any choice of osmotherapy, 3% saline over mannitol, and how do we, so there are plenty of questions, how do we make sure we have achieved adequate doses? Dr. Joseph, can you enlighten us with your wisdom, words, and all your,
Yeah.
Yes.
Okay. So we have problems with both 3% saline and mannitol. Mannitol, we assume, is doing the job. We routinely don't measure serum osmolarity to see how much of a good job we're doing, but we just sort of assume it's there. What we have found with 3% saline, see, osmotherapy works by doing what? Raising the intravascular osmotic pressure so that water is pulled out of the brain. What we find in quite a large proportion of our patients who are getting 3% saline, equiosmolar to mannitol, 3% saline and 20% mannitol are roughly equal. There's a difference of about 100 milliosmoles only in the strength. If we give equiosmolar, say that is equal to the dose, you use a calculated mannitol dose and give similar amounts of 3% saline, in a large proportion of patients, we find that the serum sodium does not come up. The serum sodium stays at 138, 141. In which case, you're not really doing osmotherapy. You're doing psychotherapy for the treating physician. But you're not achieving osmotherapy. You're not getting hyperosmolar. You need to be hypernatremic to get hyperosmolarity. Okay, it's a problem we face quite often, that we're giving 3% saline and the patient not coming up, and then we sort of add on mannitol and do weird things because the 3% saline is not bringing our sodium up. So that is the problem. So for 3% saline, you can measure whether your osmotherapy is doing something or not, whether your hyperosmolar agents are actually causing osmotherapy, you can measure. Mannitol is harder. You have to measure the actual serum osmolarity, which is not a very accurate process and not widely available.
Just to add to Dr. Joseph's point, so I think it's very important to know that you're not achieving a target. So, like for example, for mannitol, the issue is a lot of people think mannitol actually works by diuresis. Like, I think one of you actually mentioned Lasix as well. I think at some point of time, I think Abhishek did mention that Lasix wasn't given or something. I can't recall, but one of the things about mannitol actually doesn't really work by diuresis. Mannitol actually works by changing the blood rheology. So what it does is it actually causes the red blood cells to actually deform, and that changes the amount of perfusion that goes into the brain. So it's slightly different in terms of, and that's why mannitol is always very, very hard to know what targets you're achieving as compared to 3% hypertonic saline. But that being said, there's a lot of, not controversy, I think there's a lot of questions being asked, because I have been trained in the era where 3% hypertonic saline was a second line. You used to give mannitol because it was very easy to judge. You give 100 mils, you give 200 mils, give 0.5 mils per kg. So it was very, very easy to make the decision as to how much mannitol you want to give. So what I do currently, obviously, I mean, it's run by my intensive care colleagues, but what I do, so if I'm really having refractory ICP, I usually give them mannitol, and instead, because mannitol is usually a TDS dosing. So what I do is I do TDS dosing of mannitol, and I do a TDS dosing of 3% hypertonic saline, which is in between mannitol. So you have both basically, but obviously you have sodium targets when you start giving 3% hypertonic saline. And to answer the question, actually, there's this trial called the SOS trial, which is called the sugar versus salt trial, which is currently being conducted in UK with Cambridge as the main center, which is, I think, going to run over the next couple of years. So you should have a true answer if one is better than the other. There was indeed a meta-analysis that was done with some of the studies from Center TBI that showed that hypertonic saline had slightly a better benefit than mannitol, but it wasn't good enough to change practice. Yeah.
One more query was there. When the anticoagulation they should be started. So what our practice is, during 5 days at our hospital, we don't give any anticoagulation. We assume that giving any anticoagulation will lead to increase in the size of contusion or increase in the size of intraparenchymal bleed. We start with mechanical prophylaxis for 5 days, and after that, if say patient requires a DVT prophylaxis because of low GCS, because of immobility, or because of concomitant spinal injury, so after that we start on enoxaparin, that is Clexane, either in a 0.6 or 0.4 as a prophylaxis dose. Then the second question is, yes, a couple of things on the ICP. I think we have cleared that. Yes, what should be the line of management in a hemodynamically unstable patient with anisocoria with low GCS? Patient is unstable for CT and has to be taken for damage control laparotomy. Is there any role for damage control craniotomy? Dr. Vimingte, would you like to answer this?
Okay, thanks for the question. There's always a big problem when it comes to multidisciplinary approach, multi-trauma patients. For me, it's always that the hemodynamics plays the biggest role for the patient. And if the patient is hemodynamically unwell because of intra-abdominal bleed, we should stop it first. From my practice in my institution, in fact, most institutions that I do work in, after we do damage control laparotomy, which means that we actually take a minimum amount of time to truncate the operation, to buy time, we actually push the patient then down for CT brain or CT pen scan if the patient has not yet had any other scans. So for example, if the patient has a very bad bleed on the mesentery, we stop the bleeding, pack the abdomen and get out. If the patient has a bleeding from a spleen, we do a splenectomy and we get out. So as short a time as possible. At the same time, we monitor the hemodynamics of the patient. we inform our neurosurgery colleagues and we push the patient down to the scan room after the surgery directly from the OT. At a point in time in the scan room, usually the neurosurgeons will meet us and we'll discuss what's the next step for the patient. We reserve the OT for the patient. In other words, if there's a need for decompression, we actually then bring the patient up to the same OT and then continue our craniotomy from there. I don't think, I'm not sure whether there's any new evidence for a role of damage control craniotomy without any CT brain for the patient. Maybe the neurosurgeons can comment on that, but for my thought is probably no. Yeah.
Yeah, Ming, thanks. I think both Ming and I obviously work in the same place. So we've had cases where, because if they manage to get a scan and patient is hemodynamically unstable, plus there's a cranial injury. So we have done an exploratory laparotomy as well as a decompressive craniectomy at the same time. We have done, way beyond, there was recently a case where my patient needed an EVD. The trauma side, they needed to pack the laceration, they needed to do a testicular fixation. So there was a lot of things going on, but the theaters can support, and usually the GS side, the trauma side, tends to be a lot quicker, because I think your time is of essence, versus neurosurgery we can't really talk about, or do you need to finish your decom in a certain amount of time, because that is pretty much slightly different ways. So I won't go into that. If you can let me share my slide, I can show you a bit of picture about these exploratory craniotomy, which we don't do, but there actually exists a bit of evidence for doing this. Let me see if I can share my slide. I do have a picture. Yeah. Can everybody see the PowerPoint presentation? I think you should be able to see. Yeah. Majid, can you see the PowerPoint presentation? Yeah, I'm just going to show this picture. I'm not running through the presentation. So this is one of the talks I give in a course that I call it Essentials of Neurotrauma. So I just wanted to show you what exploratory burr holes actually mean for people who don't really know. So it's not exactly a damage control craniotomy, but this is in the absence. You have a dilated pupil, you don't have a scan, and you're in the middle of nowhere, which usually happens to be for conflict zones, or in settings where, to transfer the patient to a neurosurgical unit is going to take really long. So it really starts with deciding where your dilated pupil is. So what you do is you start with the dilated pupil side, because you assume that the craniotomy, that the main problem is going to be on the dilated pupil side. So you basically do a temporal hole first, because you want to decompress relatively quickly. And if you see a subdural there, that's where the thing is. And this is in the setting you don't even have any of your mechanical drills, and you're using a handheld drill and a jiggly saw. So you put a burr hole at the temporal side, you put a burr hole at the frontal side, and a parietal and a frontal side, and you basically connect all of them, if you have confirmed that that's where the subdural is, because you do need to check all the burr holes. You can have a Conohan's notch, where you are going to have a contralateral dilatation of pupil. So if you don't find anything over here, you do one on the other side, repeat the process. Both are negative, you put a burr hole in the pos fossa, because that's the last place you're going to look for if there is no thing. So there's not exactly a damage control surgery that you do, but you do have this thing role of exploratory craniectomy. And this is really, if you look at the WFNS set for craniotomy, there's a jiggly saw and there's a Hudson brace. And you guys can email me if you want to know a bit more, but that's just a bit of information I thought I'll give. Yeah.
Yeah, I think you have clarified most of the things. There is nothing as damage control craniotomy, but yes, we do inspect by making a small burr hole, like she pointed out, first on the dilated pupil side. And if that is not there on the opposite side, then maybe on the posterior aspect. And based on the finding, you can extend this burr hole to craniotomy and take out the SDH or do a decompression and decrease the ICP. The other question, what about the anti-epileptic in traumatic brain injury and how long it should be given? I think it's very clear. According to the Brain Trauma Foundation guideline, we should give it for 14 days. And after that, we can taper and stop that. There are other things like usually patients with what our practice at our center is in a patient with subdural hematoma or intraparenchymal hematoma, they have got the highest chance of having a seizure episode. So we usually keep him for say 1 month. Because again the follow-up is very limited, and most of the people, they come from far along places, and if there is any seizure they can't detect, and then we can somehow patient can land in problems. So give it for 1 month, but after that we taper it and then we stop it.
Majid, sorry. I just want to clarify because I'm not sure. So, because from my understanding, what the practice I follow is based on the 1990s paper of using phenytoin. Obviously, we have changed it to levetiracetam. We don't use phenytoin anymore in my center, but we give it actually for 7 days. I think the BD5 actually says for 7 days in the absence of any seizures. So the only evidence of giving anti-epileptics is actually to prevent development of chronic seizures. So it actually, there's from that paper alone, the evidence for giving anti-epileptics to prevent acute seizures doesn't really exist. And like what Majid said, it's very important to know where your patients are going, because sometimes you see a contusion, you know the likelihood of seizures is very high. So the guidelines are pretty much out of the window. So you give them longer because you do not know if they're going to come back. Again, there's actually a multi-center trial with one of the centers actually happening. I think they have recruited, I don't think it's CMC Vellore. I can't remember. They've recruited one of the centers in South India, which is going to do the MAST trial as well, which is basically they're looking at a role of anti-epileptics in TBI. It's a truly a randomized control trial in terms of randomizing it to, to the arm where you give them anti-epileptics or you don't give them anti-epileptics. And if you do give them anti-epileptics, what kind of anti-epileptics they're giving. So I think that study is meant to finish at the end of next year. So again, we're going to have some good results. Yeah.
Okay, can I say two things?
Yes, sir.
One is, Dr. Swati was saying exploratory burr holes in places which don't have facilities. Well, when I started doing my neurosurgery training, we didn't have a CT scan. Okay. Then for 2 years, we had a CT scan which is available during the daytime, but not available at night. And our method of diagnosis of hematomas of any TBI was a direct carotid puncture angiogram. We stuck a needle into the carotid artery and then did angiograms to see where the lesion was. And we were all quite expert at diagnosing lesions. Exploratory, and if that took time, so if patient came with a dilated pupil, you went directly to the OR for exploratory burr holes. I have horrific memories of doing those things. They are messy, they are long, they are, do one side, do the other side, clean one side, drape, clean the other side, drape. It sounds theoretically good. When you actually have to do it, believe me, it's no fun at all. The second thing that came up a lot during the thing was, high-speed monitoring, really necessary, not necessary. I'm a believer in high-speed monitoring. We do routine high-speed monitoring. We do 85-90% of our high-speed monitoring with a number 8 infrafeeding tube, a 2.7 millimeter infrafeeding tube in the ventricle, connected to a pressure transducer. All right. We've been doing this now for 30 years this way. And on the message, I'll put out the technique of how to do it. I just put it into the chat. Publication done almost 25 years, more than 20 years ago. We do that. And I found that, when I first put my first high-speed monitor, I thought I would find hematomas early, operate before the pupil dilated and be, that. That damn monitor went ding, ding, ding every 10 minutes. And it was really frustrating. But then I found what high-speed monitoring was doing was not picking up hematomas early. What it was doing was picking up deficiencies in our care that otherwise would not have been picked up. The nurse put the patient's head end down to slide the patient up the bed. Forgot to raise the head end again. If the ICP alarm hadn't told us, that patient would have stayed head down with impaired cerebral perfusion for that long. The ventilator settings went off. Patients fight in the ventilator. ICP monitor goes ding ding. Okay, carbon PCO2 goes up. ICP monitor alarms you. So what I find ICP monitoring does is not so much pick up hematomas as pick up things that we are not doing adequately in our routine care. And if we hadn't had the ICP monitor, we would not have picked up those deficiencies in our routine care, and therefore our patient care would have suffered. Do you understand? So I'm not saying ICP monitoring as a means of deciding whether to ventilate, as a means of deciding whether to operate. That aspect of ICP monitoring is debatable. But the fact that ICP monitoring improves the care of patients in your ICU, the routine care, the sedation, the ventilation, the oxygenation, is indisputable. So from that point of view, I would push ICP monitoring.
I think it's really important for all the junior residents in the chat that how I think what Dr. Joseph has said is very important. These very simple things, head up, making sure they're not struggling with the ventilator, keeping the collar off if they don't need the collar, not making sure their neck veins are not kinked in the way the head is positioned. We tend to ignore them because we want to look at the big picture. We want to look at the big things, but all these small things make an absolute difference. How many times I've walked into ICU and my resident has told me, oh, Dr. Swati, the patient's ICP has been above 30, blah, blah, blah. And I walk in and clearly the patient's head is this way with the craniectomy done on this side. And, clearly and as soon as you position, patient's ICP is 10. So those little things, I think it's very important for all of you out there who do manage, whether polytrauma or you do have neurotrauma without, a neurosurgeon being around. Just look at BDF, just look at a tier 1 management. That is extremely important. Everything else is an adjunct. Yeah.
So now that we are reaching the end point, I would ask Dr. Mathew to give the final comments.
Mathew just finished doing comments. Anyway, okay. So in the end, okay, three statements I would like to make. One is that question on unstable patient, with abdominal injury. I would not even bother about the head. First, get the blood pressure stable, then look at the head. Our institution policy is patient cannot be stabilized in the ED because of abdominal trauma. Patient goes to the OR. And the scan is done only after the BP is stabilized. All right. See, basically, what you're doing in TBI is two things. Any TBI management, finally, what you're trying to achieve. One is make sure the brain is adequately perfused with well-oxygenated blood. That is one target. The second target is prevent tissue shifts, which can compress vital structures, basically herniation. In essence, that's all TBI management is. Make sure the brain's getting enough oxygen and make sure herniation doesn't happen. How you go about it, medical, surgical, is, it depends on the individual patient.
Thank you so much. And we come to the end of this webinar, very interesting webinar, and we had a lot of discussion. I thank Dr. Mathew Joseph, Dr. Swati Jain, and Dr. Ming for such interesting discussion on this topic. Thank you, Majid, and thank you, Abhishek, for the case presentation. And I thank all the people who have joined our today's webinar. Before we end up, I would like to tell that the next webinar would be presented on critical airway in crisis, a trauma surgeon's dilemma by MGM University, Navi Mumbai. And if Dr. Sanjay Doke is there, Dr. Sanjay wants to make a comment for the next trauma conference. So quickly, if he can share his slide.
Yeah, can I share my screen?
Yes, please.
Okay. From NGM Institute.
Yes, we can see the slide. Yeah.
Yeah. So we invite all of you for TraumaCon, the 15th annual conference at MGM Navi Mumbai. We will on 20th November 2025, we'll be having workshops, and we have a very good, excellent cadaveric lab, and the method of preserving the bodies is very unique and is one of the best in the countries. So the workshops are really going to be the treat to watch. So we would like you to register for these workshops, which are on the 20th November. The conference will be happening on 21st and 22nd November 2025. All the details will be up on the website, TraumaCon 2025. And 30th June is the time when you will get the combo pack where ISTAC membership as well as the conference registration. All that can happen in one go. And the early bird prize is there till 30th June. So I will request many of you to just take the offer of the early bird and get yourself registered. We are all set and ready to invite and host you in Mumbai.
Thank you, Dr. Sanjay. And I request all the ISTAC participants and members and their colleagues and friends to get an early registration benefit by registering for the conference. And goodbye now. And next time again, we meet with MGM Navi Mumbai for the next webinar. So thank you everyone
Thank you.
for joining,
Thank
and
you.
thank you
Thank you.
panelists
Thank you
and chairpersons. Thank you.
Thank you.
Thank you, Mazid.
Thank you. Thank you, ma'am.
Thank you.